Hello everyone, a very warm welcome to everyone in today's video of thyroid carcinoma part 3. Here we are going to see introduction, pathogenesis and morphology, both gross and microscopic features. Along with that, we will see clinical features of follicular thyroid carcinoma. So let's begin with introduction. We had discussed in previous videos of thyroid carcinoma that follicular thyroid carcinoma accounts for 5 to 15% of total thyroid carcinoma cases, and this is most common in women, and the ratio of affected women to affected men is 3 is to 1, and it most commonly affect to older patients, and uh, the peak incidence is 40 to 60 years of age, and 20 to 25 to 40% of this thyroid cancer is most frequent in the areas with iodine deficiency. And so this follicular thyroid carcinoma is also called as thyroid carcinoma of iron deficient areas. And pathogenesis, we first go through this uh, you know you can see this follicular thyroid carcinoma. First, there is a point mutation in phosphatidylinositol 3 kinase, and next we see there is a uh, point mutation in P10 gene. That also results in follicular carcinoma, and also the mutation of this RAS gene, which is oncogene, that also result in follicular carcinoma. And next there is a translocation of the certain gene, and that also lead to the follicular carcinoma. RAS mutation, which we can appreciate here in the figure, that RAS mutation account for 30 to 40% of the pathogenesis of this follicular thyroid carcinoma, and this mutation occur in various RAS gene of the RAS family, like the NRAS, HRAS, and KRAS, and mutation in such gene results in the overstimulation of this pathway, and eventually lead to the over cell growth, proliferation, and differentiation, and resulting in the follicular thyroid carcinoma. And next there is a translocation or rearrangement where we had appreciated earlier. And what happens that these genes, this PAX8 gene and PPAR gamma gene, these are present on the chromosome 2 and 3. So this PAX8 gene is present in the chromosome number 2, and in the 13th band of the Q arm, that is long arm. That means this PAX8 gene is present in the 13th band of the long arm of the chromosome 2, and this PPAR gamma gene is present in the 25th band of the short arm of the chromosome number 3. So these are the breaking point where such gene are located and breaks off, and they get rearranged, and this translocation or rearrangement also lead to the exaggerated proliferation and differentiation of the cell, resulting in the thyroid carcinoma. And next we see there is the fusion of this PAX8 and PPR genes, that is called the rearrangement, and results in roughly one third of the follicular thyroid carcinomas cases has such types of fusion gene protein, which is due to the translocation and rearrangement of these two genes, and this account for 50 to 50%. Another gene could be like activating mutation in the AKT1 or phosphatidylinositol 3 kinase, and that are involved in PI3K AKT pathway, which is a very crucial pathway for growth and differentiation as well as proliferation of the cells. And there is a loss of function mutation in PTEN, because these are the inhibitory genes which act in this pathway to inhibit this growth signaling pathway of PI3K IKT pathway. So if there is loss of function mutation in this PTEN, then this inhibitory effect will be lost. So this will also lead to overexpression of the such gene, as well as these growth signaling pathway will be overexpressed. Next, there is a gross morphology of follicular thyroid carcinoma. You can see the gross findings are in appearance. These are solitary and film nodules appear as like this, and the color vary. That is from gray to tan to pink when we cut, and the shape will be that means the nodule will be well circumscribed and encapsulated, and the capsule will be thicker than that of the benign adenoma. You can see this thing in the previous video of thyroid carcinoma in the video first. And size vary, that mostly less than 5 centimeter in size, and texture is bulging. When you go through the cut surface, the texture will be bulging. And sign of malignancy grossly what features will determine that there is the transition of this follicular adenoma or follicular thyroid carcinoma to even more malignant case. And there will be the capsular invasion. The tumor penetrates the capsule into the surrounding thyroid tissues, and also there will be vascular invasion, and that show the areas of hemorrhage and necrosis, and this will also extend the tumor to blood vessels, and this will show the feature or the sign of malignancy. Next is differentiating. What features will differentiate this carcinoma with the benign nodules? Uh, Generally, in the benign adenoma, the capsule which encapsulate the nodule will be thin. But in case of malignancies, or in case of this follicular thyroid carcinoma, these capsule will become thicker and thicker, and this is the most distinguishing feature of follicular thyroid adenoma and follicular thyroid carcinoma. And invasion, there will be the full thickness capsular penetration in follicular thyroid carcinoma, which is not the feature of the adenoma. And microscopically we can appreciate the follicular pattern of the growth, and that is surrounded by the uniform cell, and that uniform cells will form the small follicles containing the colloid in the center. And nuclear features, while we go through it, there will be no Shamoma bodies, and these Shamoma bodies are the feature of the papillary thyroid carcinoma. And tumor cell is dominated by the cell which has abundant granular eosinophilic cytoplasm, which often called as orthol cells or oncocytic variants of the follicular thyroid carcinoma. And this is widely invasive. There will be some cases of follicular thyroid carcinoma which will be widely invasive, and those will infiltrate the parenchyma as well, and extrathyroidal subtissues along with it. And vascular invasion, that means only that will invade the capsular vessels and the area around that. And also there will the presence of the tumor blocks, once that will invade the blood vessels in the capsule as well as the intertumoral blood vessels, then there will be, the presence of the tumor blocks, which is formed from the tumor cells, from the deposition or from the accumulation of those tumor cells, which has abundant granular eosinophilic cytoplasm, such will form the plug. And the greater proportion of the solid or trabecular growth pattern will appear in the follicular thyroid carcinoma. Similarly, the lymphatic spread is not so common in this case. And what clinical feature we can appreciate here are slowly enlarging painless nodules will appear on the neck, and the cold nodules on scintigraph. Cold nodules in the sense that when we inject the radioactive iodine, then that nodules will not take up these radioactive iodines, and that will not create the hot spot as in other functioning thyroid adenoma. But mainly the non-functioning thyroid adenoma will lead to malignancy or lead to follicular thyroid carcinoma, which also shows the feature of these cold nodules. You can go through the video of thyroid adenoma regarding such thing. And there is a little propensity of for invading the lymphatics and regional uh, lymph nodes, and also there will be vascular dissemination with metastasis to bone, lungs, and liver. And in case of widely invasive follicular thyroid carcinoma, the systemic metastasis may present, and in half of the patient, that will reoccur back within 10 years. Such features can be appreciated in those cases where there is widely invasive follicular thyroid carcinoma, and minimally invasive cases have more than 90%. That is, more than 90% of these minimally invasive variant will survive more than 10 years. And treatment, we can treat with total thyroidectomy, and for after treating this we can administer the radioactive iodine for the, and patients are treated with thyroid hormone after the surgery, and this we do to suppress the endogenous thyroid stimulating hormone levels. And serum thyroglobulin levels should be monitored for monitoring the tumor reoccurrence. This much for now.